Okay, this is part 3 of 4 of the same presentation of grade 5 passive mobilization of the spine. Here we'll talk about the general principles as well as the self-reflective process to allow for continued improvement of this psychomotor skill.
Okay, next on the agenda is the introduction of general principles for HVLA techniques. Okay, so before we jump into the specific techniques, the art of manipulation is very individual, requiring HVLAT techniques to be applied to the need of both the practitioner and the patient. Of the techniques that are described, there are going to be some modifications within clinical practice based off your comfort, the patient's range of motion, the tropism that we discussed, and other factors that may otherwise arise with tissue tension, pain, symptoms, etc. That being said, that there's these primary underlying principles that remain the same. The principles can be summarized as follows: excluding contraindications, obtaining informed consent, ensuring patient comfort, ensuring operator comfort and optimal posture, using the spinal locking or apposition, and then identifying appropriate pre-positioning tissue tension, and then the actual application of the thrust itself. If these principles are applied, HVLAT techniques provide safe and effective treatment options. All right, so the first concept that I want to introduce is minimal leverage positioning versus barrier positioning. So operational definitions, the barrier positioning is positioning the facets where slack has been removed from the soft tissue and the facet joints are essentially quote-unquote locked or engaged at their end range of motion. It's thought to be most effective to achieve the goal of gapping the facet joints, enabling it to move beyond its normal physiological range of motion without exceeding an anatomical limit. However, it can result in full end range leveraging being used in the positions that are often uncomfortable for the patient. And then with the additional velocity-based movements of the actual thrust, this can leave the patient sore thereafter. So the alternative and the technique that we'll be teaching today will be the minimal leveraging positioning. And it opposes the barrier positioning in the sense that it uses the facet opposition as well as the ligamentous myofascial tissue tension to create a mid-range artificial barrier. The minimal leveraging position is not at end range or at the motion restriction barrier, but rather within the mid-range of what is otherwise available for the person's cervical spine or lumbar spine, depending on the particular spinal region in question. The goal is to use the least amount of leverage that will enable the practitioner to safely and effectively achieve a cavitation at the target segment in a position that is most comfortable for the patient. And it does require quicker velocity. So velocity or momentum-based thrusts enables practitioner to use less leverage in the pre-thrust positioning. All right, so the first concept that I want to introduce is minimal leverage positioning versus barrier positioning. So operational definitions. The barrier positioning is positioning the facets where slack has been removed from the soft tissue and the facet joints are essentially quote-unquote locked or engaged at their end range of motion. It's thought to be most effective to achieve the goal of gapping the facet joints, enabling it to move beyond its normal physiological range of motion without exceeding an anatomical limit. However, it can result in full end range leveraging being used in the positions that are often uncomfortable for the patient. And then with the additional velocity-based movements of the actual thrust, this can leave the patient sore thereafter. So the alternative and the technique that we'll be teaching today will be the minimal leveraging positioning. And it opposes the barrier positioning in the sense that it uses the facet opposition as well as the ligamentous myofascial tissue tension to create a mid-range artificial barrier. The minimal leveraging position is not at end range or at the motion restriction barrier, but rather within the mid-range of of what is otherwise available for the person's cervical spine or lumbar spine, depending on the particular spinal region in question. The goal is to use the least amount of leverage that will enable the practitioner to safely and effectively achieve a cavitation at the target segment in a position that is most comfortable for the patient. And it does require quicker velocity. So velocity or momentum-based thrusts enables practitioner to use less leverage in the pre-thrust positioning. Okay, so the rationale for the positioning of the patient and for the technique will predominate on many factors: facet tropism, vertebral level, intervertebral disc height, and potentially even back pain. There will be occasions when the model outlined needs to be modified to suit the individual patient. So take what we've discussed as like a theory approach. However, within clinical practice, there may be some alternatives and additional levers that need to be applied. And as you become more comfortable with the said techniques, you'll start to recognize these scenarios and what additional levers need to be applied in order to be successful with the minimal leveraging barrier positioning. The operator will need to adjust the patient position to facilitate effective localization of forces and patient comfort. To achieve this, the operator must develop the palpatory skills necessary to sense the appropriate pre-thrust tensioning and the leveraging before delivering the high velocity, low amplitude thrust. So on the last slide, we introduced the fact that facet tropism may be a factor that would otherwise determine the positioning and or the coupling motions that you introduce. And so if you're familiar with it, great. If you're not, I just want to take a moment and recognize what it is. And so facet tropism is when there's an altered angle of the facet joints as they align at a given segment of the spine. So you can see the example here where in the quote-unquote normal, or the facet joint that does not demonstrate a tropism, is that the angle at which the facets on the left and the right meet is equal. They equal as far as the degree. However, there can be an offset of this, where if you actually draw the parallel lines in, you can do so via cross-sectional MRI image as shown here. You can see that the lines do not cross or meet at the apex or the center of the vertebral body. And an example here is where they have 35 and then 47 degrees, which would be an example of facet tropism, which may change how much flexion that you would otherwise introduce, how much rotation you would introduce at this given level, even if you did a thrust mobilization on one side versus the next. There may be subtle differences. Okay, the next general principle is running through a pre-thrust checklist. And this is really just a reference for yourself so that you can familiarize yourself with it and then mentally and more implicitly go through it within your clinical practice. So before applying the thrust, have I excluded all contraindications? Have I explained to the patient what I'm going to do? Do I have informed consent? Is the patient positioned appropriately, and are they comfortable, i.e. the minimal leveraging position? Am I in a comfortable and balanced position? Do I need to modify any pre-thrust physical or biomechanical factors? And we'll talk about what these are with the continuous improvement model of HVLA in coming sections. Have I achieved appropriate pre-thrust tissue tension, i.e. again, not at end range? Am I relaxed and confident to proceed? And is the patient relaxed and willing for me to proceed? Remember, the safe application of the HVLA thrust techniques is critically linked to comprehensive training, skill development in the delivery of minimal leveraging / non-end range techniques, and skill refinement through regular practice. Okay, so there's several ways that these techniques can be laid out and described. for clarity of the logic that is used within the manual provided, is that each individual technique is logically organized under a number of specific headings: contact points, applicators, patient positioning, operator stance, the positioning for the thrust, adjustments to achieve appropriate pre-thrust tension, immediately pre-thrust, and then the actual delivery of the thrust. And then you'll notice also within the lab manual that there's QR codes that you can scan, so that as you read through these logical points, that you can also visualize the technique live time. Okay, we're going to digress from our spinal techniques that we were going through with the cervical and then the lumbar spine. We're going to talk for a moment about the continuous improvement model when it comes to learning this psychomotor skill and the ways that we can continue to evolve this skill over time. The continuous improvement model as a means of self-reflection for HVLAT mobilization technique. Okay, so in order to continue to improve and elaborate and refine the skills that you gain in today's lecture and lab session, it's going to be important for you to be able to properly self-reflect on the different components that are introduced and the different factors that go into performing an HVLAT. And this model is essentially a guide to help facilitate that self-reflective process. So the model starts with actually performing a thrust technique. Then considering, in the presence, if the technique does not go as otherwise expected or optimal in your opinion and or the patient's, then there's going to be a general technique analysis. Once you do that, the next step is to look a little bit closer at the practitioner and the patient variables. Consider the physical and biomechanical modifiable factors. Identify the specific area for improvement based off the 3 different sections previously described. And then return to detailed technique description, and then continue to practice. And so we'll step through essentially the components of each of these major categories, starting with the general technique analysis. So you can lump this into incorrect selection of the technique, inadequate localization of force, or ineffective thrust. And you can break these down even further into the following points. So incorrect selection of the technique: the practitioner is too small and the patient is too large. The practitioner has physical limitations that limit effective delivery of the technique. The practitioner inexperience with the selected technique. Inability to position the patient due to pain, discomfort, or physical limitations, and or the patient apprehension. Inadequate localization of force can be broken down into the 3 following points: incorrect application of the primary, secondary, or tertiary levers, inability to recognize appropriate pre-thrust tension. The ineffective thrust: loss of contact point pressure, poor bimanual coordination, meaning that the thrust is not equally applied with both short and long lever applicators, inadequate velocity of the thrust, incorrect amplitude of the thrust, incorrect force, loss of leverage of time of thrust, poor practitioner posture, practitioner not relaxed, failure to arrest, thrust, and leverage adequately, and lack of practitioner confidence. And then each of these checklists are also provided for you in your lab handout and manual. So again, the slides will kind of list off each of the different components, but you can see kind of a clear workflow and thought process within the lab manual itself. Okay, Moving on, so if all those components are otherwise in check and you have kind of assessed those, you also want to consider the practitioner and the patient variables. Okay, so the common faults for the patient and the practitioner variables include the following. The patient's not comfortably positioned. They're not relaxed. Potentially rough patient handling. This can occur particularly early on when learning a new technique, where there's a lot of co-contraction on the behalf of the operator, which makes it, which increases the actual contact pressures. The rushing of the technique, poor practitioner postures, and or lack of practitioner confidence in performing the technique. So though these are the common faults, we'll break down the patient and the practitioner variables a bit more. The patient comfort is going to be dependent on the confidence of and trust in the practitioner, the patient's experience with prior HVLAT, slow, firm, and gentle patient handling, confident and reassuring approach by the practitioner, explanation of the technique, and informed consent, optimal patient positioning. And the patient positioning is dependent upon appropriate positioning to match the patient's physical and medical condition, correct identification of the primary and secondary levers, the pain-free position, and the appropriate use of pillows and treatment couch adjustment. Couch here refers to the plinth. Okay, so now moving on in the model to the physical and biomechanical modifying factors. So the most common faults when it comes to the physical and biomechanical modifying factors include insufficient primary leverage, too much secondary leverage, thus leading to a locking or a barrier locking of the joints. This can occur during the buildup of leverages or at the point of the actual thrust. Loss of contact point pressure immediately pre-thrust, particularly maybe with the coming off of the barrier. Not identifying appropriate pre-thrust tension and leverage before the thrust. If in doubt about the optimal thrust tension, attempt multiple light thrusts or preliminary bumps or priming techniques that we'll discuss. Incorrect direction of the thrust should be in a direction that is comfortable for the patient. Multiple light preliminary bumps, again, can assist in identification of the appropriate direction in the thrust. You saw this previously with the cervical thoracic junction manipulation provided by Peter. Insufficient velocity of the thrust, too much amplitude. This is often a consequence of too much force and or poor control. Too much force being applied, and insufficient arrest of the technique. This is often a consequence of poor practitioner coordination and or control. Put simply, here's a checklist that can help you think through the physical and the biomechanical modifying factors. Primary lever, secondary lever, the contact point pressure, identification of appropriate pre-thrust tension, the direction, velocity, amplitude, and force of the thrust, and then finally the quick arrest or the ending of the thrust. Okay, and then the final steps of the continuous improvement model are going to be identifying the specific areas for improvement, and then returning to detailed technique description to better refine it if it is potentially, for example, the patient comfort, then reviewing the patient positioning and the type 1 versus type 2 coupling and ways in which you can make it more comfortable for the patient versus maybe it's really you forgot to add in one of the tertiary components that helps to better bring up the the minimal leverage barrier positioning, etc. Again, the model is really just helpful for you to be able to self-reflect and continue to independently improve upon these techniques beyond the confines of just today. Okay, thank you all so much for listening. Please feel free to leave your comments, questions, concerns, and feedback in the sections below, or contact one of us, that is to say myself, Taylor, or Lauren directly. We'd be happy to answer and provide further detail when and where appropriate.